Well, hello everyone. Thank you for being here, watching my MedCast. Today I will be talking about my PhD project, which is about exploring the attitude towards healthcare, and e-health of people living in disadvantaged neighborhoods. Before telling you more about this project, I will first tell you a little bit about me. My name is Jasper Faber. I've done my bachelor in industrial design at the Technical University of Eindhoven. After that, I moved to the Technical University of Delft, where I did my master's at the Faculty of Industrial Design Engineering. And after that, I started my PhD project also at TU Delft. This project started in September last year, so I'm now in my 8th month, more or less. For people that are not really familiar with what a designer really does, you might think that the designer is focused on the design of furniture, maybe, or the design of an airplane seat, which is true, of course. But over the years, the discipline of industrial design has moved from designing furniture to really a broader spectrum. And I like to tell you a little bit about that. So what is design thinking actually? What do designers think about? I'd like to explain it in the following graph. So you can see that there are three overlapping circles. A designer thinks about the desirability of the product. So how well it fits with the needs and the beliefs of the people you are designing for. In addition, the design must be focused on the business aspect, so the viability. How long can a product sustain over a longer period of time? And finally, there is the feasibility of the product in technical terms. So how feasible is it to make the product? And as a designer, you're focused on all these three aspects when you are designing a product. When you engage in a design process, it's often human-centered, so really focused around the user. It is collaborative, so you work together with many stakeholders, many experts. It is a creative approach. It's iterative, so you use multiple cycles often, and it's also very practical. So you use really hands-on techniques to design and to research while you are developing. This is a quote from Henry Ford, where he asks, where he says, "If I had asked people what they wanted, they would have said faster horses." And with this, he indicates that you can ask people what they want and they will tell you what they want, but do they really tell you what they want? And as a designer, you are trained in discovering what they really want. And for that, I have the following image. So at the top, you can see that there are different levels of knowledge. And for example, you can learn about what people say and what they think, but you can also learn about what they do or use on a daily basis. But even if you go to a deeper level, you can learn what they know, feel, and even dream. And while you move deeper into these levels of knowledge, also the techniques required to reach these knowledge levels is also more complex. So while you can learn about what people say and think through interviews, as a designer, you are trained to use more practical and creative methods to really discover these deep user insights. So that was a little bit about what the design approach is. And now I'm going to tell you a bit about my project. My project is part of Medical Delta program, e-health and self-management. Myself, I'm situated at the Technical University of Delft, but we also work together with Rotterdam Erasmus Medical Center and Capri Cardiac Rehabilitation Center situated in Rotterdam. For my project, we focus on a specific target group. We focus on people with a low socioeconomic status. And what is a low socioeconomic status? Well, in literature, it's often defined as someone who has low education, low income, or is unemployed. But in reality, you can see that socioeconomic status is way broader than these measures. You could, for example, think of low literacy, having to cope with daily life struggles, living in deprived living conditions, and even having a limited social network. So actually the target group is quite broad and difficult to comprehend. And because of this complexity, in this project we focus not on socioeconomic status as an individual, but socioeconomic status on neighborhood level. So really looking at certain neighborhoods and discover what is happening there. The issue with these neighborhoods or these target groups can be seen in the following diagram. Here you can see that it's about the life expectancy. And you can see that people with lower income have a 7 years shorter life than people with a higher income. And that is quite a gap, quite a disturbing insight. But there's really something we can work on. And you could ask, why is this gap so big? You could think, for example, of differences in lifestyle, adherence to treatment regimens, but even access to certain healthcare sources. One way to cope with this gap is the use of e-health. And according to the e-health monitor of 2019, we can see that e-health is used more and more over the years. Medical specialists, for example, mentioned that telemonitoring is increasing. The use of telemonitoring is increasing by the year. And while this can bring several benefits to healthcare, for example, by making it more efficient or improving the quality of healthcare, we can also see that not all groups in society benefit from this digitization of healthcare. And then especially we're talking about people with low socioeconomic status. Because what does limit someone to make use of an e-health application? Well, of course, you have, for example, literacy barriers. People who are not able to properly read or write can have difficulty to use certain applications. But you could also think of health literacy. Well, not understanding maybe difficult medical terms or how to interpret them. Also, certain self-management skills are required to make use of e-health applications yourself. Digital skills are required, so you need to know how to use certain digital interfaces or programs. And lastly, also a positive attitude towards health and e-health is required. Because there are so many factors at play that could limit the adoption of a person with e-health, it is very important to have a proper design process or development process. And usually it's recommended in many sources that you include your target group from the beginning onwards in every phase of the development. And this is called co-design. Here you can see the difference. Normally, a developer could use the insights from the theory to move on and to develop the application. But especially for a target group that's different than your own, that's so different, it is very important to engage with them in a co-design process. So really develop the intervention yourself or together. Unfortunately, because this target group is very hard to reach, this comes with certain challenges in terms of finances or time. And because of that, this integration in the development process is often left out with this target group. Now, there exist a lot of guidelines and tools for developers that can help to improve the efficiency or to improve the quality of the development process. But what we found out is that there are not a lot of guidelines available for developing e-health interventions for people with low socioeconomic status. And that is actually where my project is about. So well, I say my, but I'm working together with another PhD candidate in Leiden. Together we are working on developing e-health guidelines to improve their alignment of these e-health interventions with people with low socioeconomic status. The other student from Leiden, she is taking a more top-down approach. So researching existing literature about e-health interventions and looking how successful they have been and how that can be translated to the e-health guidelines. And I'm looking more from a bottom-up perspective. So engaging with the target group and discovering their experiences and stories, and in that way come up with the e-health guidelines. A little bit about my bottom-up approach. How does it look like? The method I use is officially called community-based participatory research. For the people that are not familiar with this type of research, I like to compare it a bit with anthropology. And in anthropology, the researcher travels to a distant location to interact with a community that the researcher wants to learn about. Often they live there for several months and really get to know the community, get their culture, their habits, their beliefs, and based on that, develop a report on what the researcher wants to know. Community-based participatory research is actually about creating this bond. So really create a long-lasting bond with the community and actually involve them in every stage of the research you are doing. So all the way from the problem definition phase towards the implementation of an intervention, for example. It depends on what kind of research you are doing. In my case, I do not travel to the other end of the world. I travel to the south of Rotterdam. According to this map, you can see that the status score of socioeconomic status in the south of Rotterdam is rather low. So therefore, it's a good opportunity to understand what attitudes there are at play. I do that by visiting a community center on a bi-weekly basis. And during such a visit, I talk with the visitors, ask them questions about their health, healthcare and e-health. And through that, discover what are their beliefs, what are their concerns, what are their stories. And based on that, I can learn a lot about their attitude towards these topics. Eventually, after each visit, I take notes. Also, after a while, I conducted interviews, which I transcribed. And this resulted in a lot of data. And out of this data, it was possible to come up with a sort of themes that were present in this data, that people said, that people thought, that people think. So for example, here you can see a theme that is about the amount of control that people think they have over their health. Or for example, the costs and benefits of practicing healthy behavior. These are still preliminary results because I'm still at this phase. But it's nice to already give you a small overview. One thing I want to mention is that when you are doing qualitative research, you are really, as a researcher, prone to your own interpretation bias because you're doing everything on your own. It's very easy to maybe misinterpret something, or it's difficult to check whether your assumptions are correct. So to counter that, I developed stories. And these stories are actually the results, but then because the results are quite abstract, I translated these abstract results into a concrete, close to real life scenario. And because of this, it's very easy for me to communicate this back to the community and ask for their feedback, to ask whether this resonates with what they are thinking. So through that, on the one way, I can validate the results. And on the other way, I can give the community a sort of feeling that they are really part of the research. They can really provide their input and discuss the results that came out. So in that way, it also contributes again to the community-based participatory nature. Well, as I told you, the results are still preliminary, so I cannot really provide a really detailed overview of what I found, but I can give you some examples. In this case, you see a story about the character, Sam, and he explains that he doesn't have a lot of control over his own health. And this is because he thinks that what happens to him in terms of health is all in the hands of chance, of luck. So there's not a lot of things he can do to influence how his health is doing. it's all in the hands of luck. It can happen to anyone. And that is something that I noticed that a lot of people were telling me, that they didn't feel that doing something about your health is helpful. So it could be really interesting for the development of e-health. So you know that how you can align it with the goals of your e-health intervention. Another example is on the topic of e-health. In this case, you see the character again, who is not really enthusiastic about e-health, because he really doesn't know why he should use it. What is the benefit of using it? And this is also an interesting insight I found, is that people explained that they didn't really were exposed a lot to technology or to e-health. So they weren't aware of the possible benefits that it could bring them, which could also be an interesting insight for the development of e-health. How are you thinking about, for example, reaching your target group, or convincing them that it is eventually beneficial to use? So those are two examples. I'm still in the process of analyzing the results. If you're interested in it, I put my email address in one of the slides. So you can always email me at a later stage if you're interested in the results that came out. Also, if you have any other questions, you can visit the Facebook group or send me a message. And yeah, thank you for watching.